from Lenny Hamukoto, one of our senior registrars at University of Cape Town. She'll be giving us a talk on controversies in the management of clinical stage 1 testicular cancer. Very interesting talk. Thanks, Lenny.
Yes, good morning, everyone. Are my slides visible, or can you hear me clearly?
Very well, thanks, Lenny.
Okay, thank you. Sorry, I'm Heleni Hamukoto. So the topic that we're discussing today is the controversy in the management of clinical stage 1 testicular CA. Just to start off with epidemiology and the etiology. Testicular cancer, it's found to be a rare cancer, which is accounting approximately for about 1 to 1.5% for all cancers in men. And a diagnosis, only about 1 to 2% were found to be bilateral. And the predominant histology is usually a germ cell tumor. The peak incidence usually in non-seminoma germ cell tumor is usually in the 3rd decade, while for pure seminoma is from the 4th decade. With the risk factor, it is common more in the Caucasian or Hispanic men, and the risk factors are found to be cryptorchidism, which is 4 to 6 times more common, but these actually become less or better if the orchidopexy was done before puberty. It is found to be 2 to 3 times if the orchidopexy was done before puberty. And the other risk factors is family history, which is more common in siblings compared to sons. And if the patient also, one of the third risk factor is a germ cell neoplasia in situ. It is also associated with HIV, and these patients often get seminoma rather. With the TNM staging and classification, I'm not really gonna spend much time going through this. So I'm gonna just skip the slide, but it is important to do the TNM staging. And according to the AGCC 8th edition, the T1 for seminoma is divided into PT1A, that's based depending on the size of the tumor. So which is T1A if it's less than 3 centimeter, and T1B if more than 3 centimeter in dimension, which is only applied to seminoma. So the stage group, the group that we're gonna look at in terms of controversy in management is the stage 1 that I just highlighted there, which can be stage 1A or B. In terms of risk stratification or this stage, clinically stage 1 is usually divided or risk stratified into either low risk or high risk. And that's based on histopathology type. And for seminoma, so this stratification is based on tumor size, if it's more than 4 centimeter, or if there's any invasion to the rectal testis. Is indicated on the diagram. And for non-seminoma, it's risk stratified as a high or low risk based on if there is lymphovascular invasion or any percentage of embryonal carcinoma more than 50%. So with risk stratification, also the predictors of relapse for clinical stage 1 disease is based on a risk-adapted approach, which for non-seminoma, the exact percentage of embryonal carcinoma, which that confer the increased risk remain unclear. And the argument on the presence of embryonal carcinoma, the other like the EUA actually referred to as it's indicated in their column, that they use embryonal carcinoma percentage more than 50% component. But if we looked at the other, the Canadian, the Prince Margaret group suggests only if they only consider if it's pure embryonal carcinoma, which is 100% as a risk factor. And because of this disagreement over the embryonal carcinoma component, so we often, the LVI is more a predominant factor, which is being used as a risk adapted guideline, because there is a lot of controversy in terms of the embryonal carcinoma percentage. So clinical stage 1, testicular cancer, so this represent organ-confined disease, and patients have negative tumor markers, and this represent approximately 70 to 80% of men at presentation. And regardless of the management, clinical stage 1 has excellent prognosis, and however, without adjuvant treatment, if patients are being treated with active surveillance, there is approximately 30% of non-seminoma germ cell tumor and 15% of seminoma risk of relapse. While surveillance have become the standard for most patients with clinical stage 1 disease, there is still it is still debatable in terms of management of patients at high risk of relapse. And the controversy in the management of this stage of patient, the optimal balance between the morbidity of over-treatment and the identification of patients who might benefit from adjuvant treatment, that's what caused more controversy in managing this, because we have to balance, there must be an optimal balance between the morbidity of over-treatment. So the overview of management option for this group of patients, in a seminoma group, there's 3 options, which one can offer active surveillance, or can offer radiotherapy or chemotherapy with carboplatin, which can be given as a 1 or 2 course. According to the EUA guideline, they usually, they use the risk adapted strategy, where a patient have to be risk stratified into low risk or high risk. Adjuvant carboplatin treatment using one dose, using one course of carboplatin is an alternative to radiotherapy or surveillance. And the risk for occult disease with these risk factors, both risk factors, is about 32%, and without any of those risk factors that, as we discussed, the tumor size and invasion of rectal testis, the risk to occult disease is about 12%, according to the EUA guideline. As we say, this patient had to be risk stratified into high risk. And if the patient is high risk, you can offer this patient adjuvant carboplatin, which is found to decrease the risk of relapse by about 60%. While if the patient is a low risk, then you can offer them surveillance. And the advice offering surveillance is if the patient, if the facilities have, you offer surveillance to patient if there is facility available and this patient is compliant to follow up. The AUA and the NCCN guideline actually recommend that one can offer surveillance as a preferred option for all patients, regardless if they are high risk or low risk. So this is just what we went through in terms of the EUA guideline recommendation, and it is a strong recommendation that do not offer or do not perform radiotherapy as an adjuvant treatment. So moving on to the non-seminoma germ cell tumor for clinical stage 1. So the management options, these include active severance, retroperitoneal lymph node dissection, or chemotherapy, which is BIP, can be 1 or 2 cycles. And according to the EUA guideline, it is a risk-adapted approach where you have to stratify them into either high risk or low risk. And for high-risk patients, you can offer them chemotherapy as a standard option, or RPRND. This should be offered in highly selected patients if they are there is some contraindication to offering them chemotherapy, or patients unwilling to severance. And for low-risk patients, you can severance is actually a standard option, but you can offer them chemotherapy if they are unwilling to have or they are not keen for severance. While for AUA and CCN guideline recommend for low risk, you can severance is preferred, or RPRND or chemotherapies are alternative to patients who decline severance. And for high risk, it is, they say it's a shared decision making between the 3 options, either severance, RPRND, or chemotherapy. And looking onto the Canadian guideline, they recommend severance as a management of choice for all risk group in both seminomas and non-seminoma. And this is in line with the Prince Margaret Cancer Center, which they use the non-risk adapted approach. So if the patient is willing and able to adhere to severance program, then all these patients are offered severance. And the differing opinion regarding the risk-adapted and non-risk adapted treatment is the main controversy in terms of managing clinical stage 1 disease in testicular cancer. So these just recommendation, EUA risk adapted for non-seminoma based on the vascular invasion. As you say, the vascular invasion, that's what is more used compared to embryonal carcinoma percentage, because it differs in terms of percentage. And as we said, patients have to be grouped into low risk and high risk, and the different option that one can offer based on the risk of the patient. This is what we discussed already, that for low risk and high risk. For high risk, you offer them chemotherapy, but depending on if they are willing or not. Okay, recommendation for management of, so this is also what we have discussed already in terms of non-seminoma germ cell tumor, the EUA guideline recommendation, the standard option in both risk groups. We're not gonna go through again because we did discuss it on the previous slide already. This is also just the EUA risk adapted approach in non-seminoma, which basically they use risk adapted treatment if it's low risk or high risk, and if they relapse, one have to use the IGCCG, and then if they relapse, then you give them, depending on if they are poor risk or intermediate or risk or good, risk stratification in terms of prognosis. This patient, if they relapse, you can give them chemotherapy 3 to 4 cycle, and depending on a CT scan, if they have, depending on the tumor marker in the CT scan, one can offer them RPRND if indicated. But this is not our discussion for today. We're literally looking at the management of clinical stage 1 disease. Okay, so for adjuvant therapy with chemotherapy or radiotherapy, so the use of adjuvant treatment is mainly reserved for high-risk patient, and it is used in centers that advocate a risk-adapted approach compared to those ones that do a non-risk adapted approach, because in a non-risk adapted approach, all the patients are offered surveillance. And the argument for adjuvant treatment focus on the risk associated with non-compliance to surveillance and the intensive monitoring and cost of surveillance, ongoing psychological stress, because most of these patients, if they are surveillance, they still believe that they've got cancer. So there is associated psychological stress and also resultant intensive treatment if this patient relapse. So radiotherapy is associated with a lot of toxicity in terms of GI toxicity and secondary malignance post radiotherapy, and it's not used in clinical stage 1 seminoma, and it's less used in clinical stage 1 seminoma. And for non-seminoma, the non-seminomas are less radiosensitive, so the choice of treatment, adjuvant treatment, lies between chemotherapy or RPRND. Looking at the RPRND as an adjuvant therapy, so there is no role for RPRND in clinical stage 1 for seminoma, but there is a role of primary RPRND in non-seminoma, which is literally as a prophylactic, or it's used for staging in clinical stage 1 non-seminoma. And the benefit or the advantage of doing primary RPRND, it's long-term, it's lack of long-term toxicity, and also help with accurate staging. But this is definitely associated with high morbidity, and yeah, so part of the disadvantage. Surveillance, it's approach for men, used as an approach for men with clinical stage 1 disease. And so this help to avoid treatment beyond radical orchidectomy in about 50 to 75% of patients. And offering surveillance regardless of risk factors, it is called non-risk adapted approach, as we discussed. And the debate still exists with whether surveillance is an appropriate for patients that are high risk. This is just a table with if you offering surveillance for patients with non-seminoma germ cell tumor in terms of what to do at each visit in the first year up to the 6th year, in terms of tumor marker and chest X-ray, and also when to do a CT scan. And yeah, so when to do a CT scan at 1 year and 2 year, yeah. So this, yeah, so we're not gonna go through that much. And in terms of, there is an article that that they looking at was published actually in that was published in 2010. Sorry, this was published in 2020 on the 9th of June, where they looking at controversy in the management of clinical stage 1 testicular cancer. So this paper was literally a summary of the Canadian Testis cancer workshop that was held in Canada. So it was from the 15th to the 17th of November 2018. And the objective was to discuss the challenging area of testicular cancer care, where guideline might not be specific, and also to discuss case around and expert approach to working through these challenges. The methodology, as I said, was had in November 2018 by the Canadian Cancer Testis Cancer Workshop, which was in Toronto. And it was a 2 days workshop, and this included a multidisciplinary team, including urology, oncology, and radiologists, and also social workers, and it was, as I say, MD team discussion. So the discussion, a part of the discussion was the goal for future is to maintain excellent oncological outcome while minimizing potential morbidity of treatment. And the challenge remain to identify patients at high risk of relapse and manage them with the risk-associated treatment-related morbidity. So the prognostic serum biomarker, which such as the microRNA, which is expressed in more than 90% of germ cell tumor, might play a role in the choice of adjuvant therapy compared to severance. But as we know, according to the EUA guideline, this microRNA, literally, they said it might be useful for the diagnosis, monitoring, and prognosticating in future, but it's only present or contributing to research at the moment. So part of their conclusion was most patients with testis cancer present with clinical stage 1 disease, and regardless of the treatment approach, their outcomes are excellent. And the challenges lies in a shared decision process where discussion and choices of management option extend beyond the simple risk of relapse. But include the long-term toxicity of adjuvant treatment that might follow, and given the favorable cancer-specific survival. Okay, there is another article that I just looked at, and I thought where it was published in the EUA. This was 2010. Where they looked at non-risk adapted severance in clinical stage 1 non-seminoma, which was the Prince Margaret Hospital's experience. So the objective, it was actually a prospective study, and the objective was to report overall active severance experience and compare outcome using a non-risk adapted approach. Method was they had 371 patients with clinical stage 1 non-seminoma managed by active severance. This was from 1981 to 2005, and they divided their patient into 2 cohorts by the diagnosis date. And the initial cohort was between that year range 81 to 92. That include about 157 patients, and the second cohort, which they refer to a recent cohort, was between 1993 to 2005, and that included about 214 patients. And patients were followed up at a regular interval, and treatment was only given if they relapse at least 5 years. And the tumor marker chest X-ray were repeated every 2 months for 2 years, and every 4 months for 3 years, and 6 months for 4 years. And the CT adult pelvis was done every 4 months for first 2 years of surveillance. So their results were, so with a median follow-up of 6.3 years, about 28% relapse. This was in the initial group. So out of the 104 patients, which is 28% relapse, the 33% were from the initial group and 23% were from the recent group. As I say, they had two groups, the recent group and the initial group. With about 33% were high risk based on the presence of one or both risk factors, which is LVI positive or embryonal carcinoma percentage. And in the initial cohort, about, which include 42%, so there was about high risk, 42% were high risk, and compared to low risk patients that were about 18%. And then in the recent cohort, about 27% were high risk, and low risk patients were about 14%. The estimated 5-year disease-specific survival was about 99% in the initial group, and then 98% in the recent cohort. And disease progression was recognized within 1 year in most of the cases, and proper treatment resulted in a successful salvage of all. But they only had 3 patients that died, which is 0.8%. The conclusion of this study was that the non-risk adapted surveillance is an effective, simple strategy for the management of all clinical stage 1 non-seminoma germ cell tumor. And these findings are consistent with other published data that have reported relapse rate of 26 to 35% in the non-seminoma germ cell tumor, and also the mortality rate was also 0 to 3%. 0 to 3%, which is the same finding which they said is same finding in this study. The third article that I just wanted us to go through was also a journal of clinical oncology, where, as we said, for non-seminoma, the option is active surveillance, RPRND, or chemotherapy BIP. So they compared if to do RPRND or give adjuvant chemotherapy to this patient, which one is superior to the other. So the aim of this trial was to prove the advantage of 1 cycle of BIP and compared to RPRND in terms of cancer recurrence. And the conclusion was that in clinical stage 1 non-seminoma, offering them 1 course of BIP is actually superior to doing RPRND in terms of recurrence. So in conclusion, clinical stage 1 germ cell tumor have good prognosis. But there is a lot of controversy in terms of management option. So EUA guideline recommend management option based on a risk-adapted approach, but the Canadian use the non-risk adapted surveillance. But the treatment burden, side effect, and also the relapse risk must be considered in terms of when deciding on the what to offer for this patient. So in summary, just to say, there's still a lot of controversy in terms of management option, but EUA recommend risk-adapted approach. Thanks.
Yeah, thanks, Heleni, for an excellent talk. I think you've highlighted a few critical things on your talk that, you know, the first thing is that clinical stage 1 testicular cancer is one of the most commonest presentations. About 80% of patients do present with that. And you also highlighted that, you know, regardless of what treatment they get, patients that are amenable or willing to have active surveillance actually do as well as patients who actually, you know, who are given treatment or active surveillance in the initial stage. And like I said, the controversies really are based on the fact that there's no level 1 evidence for all these recommendations by the EUA guidelines, you know, the NCCN guidelines, AAA guidelines, in how to deal with, you know, high-risk patients more specifically. And that's why most people do recommend a risk, sort of a shared decision-making with the patient. Again, like you said, balancing the outcomes, cancer-specific survival, which is quite similar across all patients in clinical stage 1. Obviously, balancing that with toxicities of giving chemotherapy, or otherwise you add PLND and your radiation patients with seminomas. And like you said, I mean, the Canadian guidelines and the Prince Margaret Cancer Center actually do recommend that all patients should actually get active surveillance, you know, across whether they're high risk or low risk, as long as they're willing and they're able to comply with the surveillance guidelines. And again, like I said, the promising microRNA 371 that it might be in the future, the decider in how one decides which patients to surveil or otherwise treat. Otherwise, yeah, well done. That's an excellent presentation. I guess, unfortunately, we're still following the guidelines. And like I said, I think it's usually safer to deal rather with the risk adaptive strategy. And obviously, these patients need to be discussed at an MDT meeting. Yeah, but yeah, again, like I said, the issue is just we don't have level 1 evidence for all these recommendations. Are there any questions for Heleni on the floor? Okay, I'm not seeing any questions. Again, well done to you, Heleni, for an excellent talk. Unfortunately, Malcolm had to leave, but otherwise he actually said, I mean, the controversies that you actually addressed in the talk, it's actually stuff that he would have highlighted as well. Thank you so much. Well done.
Thank you, Sam. All right.